goes back more than 1,000 is quite striking. So it's wonderful to be here. So as George said, I come from a land down under. This is Melbourne down here. This is where we are today. You almost couldn't be any further away, I think. We are so far from the centre of civilization, which I think is about here. And George was very kind. IPOKRaTES has a very wide reach, but it hasn't quite made it to Australia. So we remain uncivilised in many ways, but maybe one day. Anyway, it's great to be here and to be sharing this with you. Does anybody recognise this? What is this? Tell me? This is here, right? Yeah, okay. So I'm just going to start with a link between Poland and Australia. This guy, I don't know that you can see the inscription, but this guy's name is Strzelecki. At least that's how we say it in Australia. You probably can pronounce it much better than that. But Strzelecki was a Pole who came to Australia and explored the country. He's very famous. He has a mountain range named after him. But he discovered this mountain, which is the highest mountain in Australia, and it's called Mount Kosciuszko. Very beautiful, not very high because Australia is a very old, worn-down country, but a link between Australia and Poland. Okay, so we're talking about assessment in the delivery room. And I'd just like to start by showing how things have changed in the last decade or so. And these are the ILCOR guidelines from 2005, and these guidelines have gone out through various countries, the European Resuscitation Council, I guess, to most of you here. And these are the signs that we were taught to evaluate in 2005. When you're looking at a baby in the delivery room and deciding whether this baby needs your help or not, you need to evaluate the respirations, the heart rate, and the colour. And these are three of the components of the APGAR score. The other two, tone and reflex irritability, maybe not so important. So what we base our assessment on in the delivery room, what we were taught to base our assessment on, were those three critical signs. Now, in Melbourne, we went through and examined these signs in detail to see how useful they were, how good they were, how accurate and precise they were. We started with colour, and what we did was we've got a lot of videos of babies in the delivery room, and we took 3 to 5 minute clips of 20 of these newborn babies, all sorts of gestations from very preterm to term, various degrees of resuscitation, some babies needing no resuscitation, other babies needing full bag and mask, some endotracheal intubation. And then we showed these videos to doctors and nurses, usually quite experienced doctors and nurses, and we asked them to say, when does this baby become pink? At the same time, we were measuring the baby's saturation, so we noted the oxygen saturation that corresponded to the time when the baby was said to turn pink. And this is what we saw. So there were 27 observers. Each one of these box plots is a single baby. So if we took this one, this baby, on average, people said turns pink at around about a saturation of 60. But somebody said, no, it turns pink at 40. Somebody else said, no, it turns pink at 98. So for this particular baby, there was a broad range of oxygen saturations at which the baby was said to turn pink. And if we look across all the 20 babies, we see that one baby on average was said to turn pink at a saturation of 40, right up to a saturation well into the 90s. So big variation in colour. On average, the median saturation at which babies were thought to become pink was 69. But that range extended from as low as 10 to as high as 100. So what we thought was a pretty good clinical sign, turning from blue to pink, was one, even in controlled conditions, that experienced clinicians disagreed about. And that made us wonder whether colour is a useful sign in the delivery room. And it's come to pass that in the most recent guidelines from the International Liaison Committee on Resuscitation, that's ILCOR, they've abolished the use of colour as a sign in the delivery room. What they say is that colour takes several minutes to change normally. We're all born blue. In the uterus, the fetus is blue. It takes several minutes, even for normal, healthy babies, to make the transition to a normal oxygenation. If you combine that and a wish to make babies pink as soon as possible, you are putting these babies at risk of the damage from too much oxygen. And that harms both, harms the organs at both a cellular and a functional level. So colour is now gone from all the guidelines that run through the ILCOR system. I'm just going to take a little sidetrack because it's very unsatisfying going around the world and telling people, well, colour's no good. And they say, well, give us something to believe in. At one of these meetings, a wise old neonatologist said, yeah, maybe colour globally is no good, but you can really rely on the colour of the baby's tongue. And we decided, well, maybe there is something in that. And so we tested that in something called the Giraffe study, called the Giraffe study because giraffes have blue tongues. So we looked, this work was done at my hospital by a group of visiting Swedish medical students fairly recently, so we're only just processing this, but they looked at about 70 babies delivered by caesarean section, most of them at term or close to term, average size over 3 kilos. Most of them required no resuscitation, had good APGAR scores, delivered under epidural anaesthesia. So these were fairly normal standard babies coming into the world, and people were asked to look at their tongues and say when the tongue became pink. A mixture of people asked to assess colour, a mixture of midwives and paediatricians. Most of them were experienced, at least had more than a year of looking after babies. And this little study gave us some hope that looking at the baby's tongue specifically might give us a better handle on what the oxygenation of the baby was. So this is an ROC curve, and you see the curve goes up like this and over. A good ROC curve has an area under the curve, or a perfect test has an area under the curve of 1. The curve would go right up here and across here. This is a pretty good curve. The area under the curve is 0.86, so it's a good test. It's much better than the play of chance, which would be this line, the diagonal line here. And it turns out that if you take the cutoff of 70% saturation, if the baby has a pink tongue, almost certainly it has a saturation above 70, and therefore probably in the first 3 or 4 minutes of life does not need supplemental oxygen. So there's some early evidence that the colour of the baby's tongue might be a useful way of monitoring oxygenation. Turning now to heart rate. And heart rate, we've been taught, you either put your stethoscope on the chest and you listen for the heart rate, or you palpate the umbilical cord. The guidelines say, the NRP guidelines say, you count the heart rate for 6 seconds and multiply by 10 to get the heart rate. And most of us believe that the heart rate is a very important sign. It might be the most important sign in determining who needs resuscitation and how you're going when you start resuscitation. If the heart rate is going up, this we think is a very good sign. But once again, we asked ourselves, well, when you do it this way, how precise are these measures and how accurate are they? And it turns out that this clinical sign, at least as measured, is disappointing. The box plot to the left is the baby's heart rate measured by auscultation, measured with a stethoscope. And on average, people, when they do it that way, are underestimating the heart rate by about 16 beats per minute. When you do it palpating the cord, slightly worse, about minus 19 beats per minute. So compared to an ECG, a gold standard heart rate measurement. And in addition, only 21 of the babies that had an attempted heart rate measure using palpation of the cord, could they actually feel something that they could measure. So in 5 babies, unable to measure, so about 20% of babies. So the message here was that if you're doing it that way, counting the heart rate for 6 seconds, multiplying by 10, you're likely to systematically underestimate the true heart rate by a significant amount, around 20 beats per minute. And that might lead you very much astray when it comes to therapy. It might mean you're giving cardiac compressions when the baby does not actually need them, or start to ventilate a baby who doesn't actually need ventilation. This is what ILCOR says. Auscultation of the heart rate is more accurate than palpation, but both are relatively insensitive. If you have to do something, use clinical signs, use the stethoscope. That's a better way of doing it. If you don't have a stethoscope, then palpate the umbilical cord, because the other pulses are even worse. So that's a bit depressing. We'll come back and see what we can do about that in a little while. So we moved along to ventilation. That's the mainstay of making babies better. And the suggestion was that we look at the baby's chest movement. How well is the baby's chest moving when we squeeze the bag or use the T-piece resuscitator? Or an alternative way of judging ventilation is to use the manometer to measure the pressure that we're delivering. ILCOR tells us that in those initial breaths, what we should be doing is avoiding excessive chest wall movement, particularly during preterm infants. And it tells us that if you to monitor the inflation pressures might help provide constant inflations and avoid unnecessarily high pressures. So this is the conventional wisdom, but it implies that people can judge chest movement, and it implies that measuring pressure bears some relationship to the amount of ventilation that we're delivering. And just to do the second one first, when we looked at the pressure recorded on the manometer and related it to the volume delivered, we saw a scatter plot that looks like this. It's all over the place. So we've got down here the peak inflation pressure along the x-axis, the delivered tidal volume in mils per kilo on the y-axis. You can see that most of our babies we start with a pressure of 30, or at least we did at the time this study was done. And if you set the pressure at 30 and you see the needle move up to 30, you might be delivering a good tidal volume. You might be delivering 5 or 6 mils per kilo, but you may be delivering virtually zero tidal volume, or you might be delivering tidal volumes that are up above 20 mils per kilo, so almost certainly enough to damage the lungs. So using the manometer is not perfect in deciding how much ventilation you're giving. Chest wall movement. We performed this study on preterm babies who were getting face mask positive pressure ventilation straight after birth. And what we got clinicians to do was estimate the tidal volume that they were giving, both in a quantitative or an objective sense and a qualitative or a subjective way. We got them to do it from the head of the bed. When you're resuscitating a baby, that's how you're usually looking at the baby's chest from above. We thought, well, maybe that's unfair, and maybe if you looked from the side and you could see the chest going up and down, you might do better. We thought, well, maybe experienced people are better than the newcomers at estimating chest rise and guessing the tidal volume. The bad news is, and this is spoiling the punchline, but none of these things made any difference. Didn't matter whether you were looking from the top of the baby or from the side of the baby. People who'd been resuscitating babies for 30 years versus people who'd been doing it for 3 months. What we were doing was comparing their estimates with measurements of tidal volume through a hot wire anemometer. And I'll show you some of these techniques a little bit later on. So this is what people thought they were delivering when we asked, how much tidal volume are you giving? Well, there are 20 or so babies and 20 operators, and they assigned the tidal volume that they thought they were giving. I've marked in the red dotted lines the target tidal volumes that we think are good for little babies, 4 to 8 mils per kilo. So you can see that most people thought they were delivering something in the target range. One thought they were delivering quite high tidal volumes. A few thought they weren't delivering terribly good tidal volumes. When you find out what they actually did deliver, you see that some people were delivering very high tidal volumes, on average more than 20 mils per kilo. Others, tiny tidal volumes, probably ineffective. So tidal volumes that were probably damaging the lungs, tidal volumes that would not be sufficient to establish gas exchange and would probably lead to an ineffective resuscitation. We've got 1 or 2 that actually got it right and delivered consistent tidal volumes in a therapeutic range. For many operators, combined the worst of both worlds. Some tidal volumes too high, others too low. So what we can see here that the tidal volumes delivered in resuscitations are very variable, and they bear very little relationship to what people thought they were giving. So the relationship between what this person said, I'm delivering 3.5 mils per kilo, actually delivering above 10 mils per kilo. People were getting it wrong in a big way. This is just putting it another way. This is a more subjective rating. People were asked to say, well, how am I doing? Some people said, well, we're not moving the chest at all. Some said, well, we're moving it, but it's too low. Some said, we're just about right. Some said, we're doing too much. And some said, not sure, can't really tell. And what you can see here is there's very little relationship between what people thought they were delivering. For instance, the people who thought they were delivering too low volume were actually doing very well, perhaps too well. But people who thought they were appropriately ventilating a baby were systematically delivering too low tidal volumes. So the relationship between what people thought they were giving and what they were actually giving was very weak. So what did we learn from these studies? Well, the displayed positive inspiratory pressure is a poor surrogate. It corresponds poorly with the actual tidal volume that babies are receiving. And chest rise is inaccurate. It's an unreliable measure of the adequacy of ventilation. Why might this be important? Well, it might be important for a number of reasons. Too little ventilation, and as I said, that is probably going to lead to an unsuccessful resuscitation. If you give too much ventilation, too high tidal volumes, then that's trouble too. We get some very useful information from an animal model. This is a lamb model of resuscitation done by, I think, a Swedish guy, Björklund, who was resuscitating lambs that were equivalent to 28-week gestation babies. And what he found was that as few as 6 large manual inflations, 6 high tidal volumes around the 20 mil per kilo mark, caused lung damage, caused reduced compliance of the lung, worse gas exchange, and widespread lung injury within 4 hours of those 6 big breaths. So we can do a lot of damage in a very little time if we get it wrong by giving too much ventilation. And this is some of the histology. This is a normal normal resuscitation, a standard resuscitation. So this is a low power view of the lung. You can see the alveolar structure is well maintained there. Compared to just those 6 breaths that are too big, we see a more meaty lung, an inflamed lung, a lung on high power that is full of inflammatory exudate, and the alveolar structure is greatly disturbed. So just with 6 big breaths, it's possible to do a lot of damage. So that's all a little bit depressing, how bad we are at clinically determining the colour of the baby, the heart rate of the baby, how much to ventilate babies, but we have some assistance on the way. Pulse oximetry has been around in the intensive care unit for many years and is now being applied in the delivery room. How should we do it? How accurate is it? And what are its limitations? We'll go through that. And I'd like to talk about this mainly this afternoon, but just to give you an introduction to what we might learn using respiratory function monitoring in the delivery room. So this was some work we did. It's almost 10 years ago now, when we first started taking the pulse oximeter down to the delivery room and working out how best should we put that technique to work. So we started off just testing it in the intensive care unit. We wondered, well, what's the quickest way we're going to get a signal? Because if we're going to put a monitor on and get some information about the baby, it needs to be very rapid. It's no good taking 5 minutes or 7 minutes to get heart rate and oxygen saturation data. We need it very quickly. And it turns out the best way to do that is turn the pulse oximeter on first, put the sensor on the baby's wrist or hand, and finally connect the sensor to the patient cable. And if you do that, you'll get the most rapid acquisition of data. We then took that technique to the delivery room and found that if we did it that way, that 90% of babies would have good data within the first minute and a half of life. About a half of them will have good data by a minute. We found that preterm babies, being smaller and often less vigorous, were easier to monitor than term babies. So, feasible to do it, gives you numbers within a short period of time, therefore it's potentially good. But we wanted to know that information was going to be accurate. We started off with heart rate, and we did a correlation between the pulse oximeter on the y-axis and an ECG on the x-axis, and you can see that there's quite a good correlation between the two. And you can see that it's quite a sensitive test in picking up babies with heart rates less than 100, quite specific, good positive and negative predictive values. Good at picking up babies who we want to know about, babies with a heart rate that is truly less than 100. The pulse oximeter picks up those babies very nicely, so it identifies babies who need our help. This box represents the false positives. So this is where the heart rate on the ECG is perfectly fine, but the heart rate that you see on the monitor is low. So you can see that this is quite a rare event. Only 1% of readings are in this box. These are predominantly the big term babies where we're having trouble getting a signal. They're babies that are quite tense. They're grasping their fists around the pulse oximeter, not letting it give a good reading. Those are babies that we probably don't need to monitor anyway, so not really a problem. These are the normal babies, so the vast majority of babies, and a good correlation there. And finally, the fourth box is the box that we want to be very empty. These are babies that have truly got a heart rate less than 100, and we don't want to be misled by the pulse oximeter saying the heart rate is okay. You can see there are a very few number of dots here, only 0.5% of all the dots in this box, so the rate of missing a low heart rate is very low, and it's really just a slight misjudgment of the heart rate. So the heart rate is actually quite close to 100 on the ECG. It's slightly more than 100 on the pulse oximeter. So pulse oximetry gives you a very good and accurate reflection of the heart rate, and it's continuous. You can leave it on. You don't have to stop resuscitating to listen to the baby. The pulse oximeter will give you continuous data. And that was done with the Massimo pulse oximeter, but that's not the only pulse oximeter in the world. So we wanted to make sure that this technology held up. So we tested the ILCOR pulse oximeter, compared it with the Massimo, and they're very similar in terms of the accuracy of their detection of heart rate. They're only out by less than a beat per minute. Very similar accuracy and very similar spread of the data, very similar precision. So what we found for the Massimo also applies to the ILCOR pulse oximeter. We're going to come back to oxygenation in a minute, but it's very important to know what is normal when we start to apply this technology in the delivery room. What is the normal transition in heart rate? And so we went to hundreds of deliveries and measured the heart rates of normal babies. These are normal term babies receiving no intervention, so no oxygen, no suction, just normal healthy babies. And this was a little bit of a surprise, but what we found was that many normal babies in the first minute or two of life have heart rates that are below 100. Right? And these are babies that the guidelines would tell us need our resuscitation, sometimes need our early and severe resuscitation like cardiac massage, heart rates below 100. So it's very important to recognise that normal babies can have quite slow heart rates in the first minute or so of life. And perhaps what's more important than the absolute number of the heart rate is what's happening to it. And that's where the pulse oximeter is very useful, because you can see how things are going over time. So if the heart rate is 70 at a minute of life, but is 90 10 seconds later, then you can be confident that this baby is going to be fine, and you don't need to go into full resuscitation. Oxygen saturations are the other measurement that we get from the pulse oximeter. And again, it's very important that we know what is normal, and I'm sure we'll be talking about this more through the day. But this was our attempt at defining what is normal oxygen saturations in the first 10 minutes of life. And my colleague Jennifer Dawson went to over 400 deliveries. These are, again, normal babies not receiving any resuscitation, and she just measured their saturations. And so on average, saturations start around 60 at a minute of age, and over the first 5 minutes of life, slowly but surely go up to about 90. But what took us some time to get used to, those of us in intensive care who were used to when babies had a saturation of 40 or 50, the nurses would say, come quickly, this baby's in big trouble, come and sort it out. In the delivery room, a saturation of 40 or 50 is quite normal in the first few minutes of life. This is the 10th centile down here. So 10% of babies have saturations down around 30 at a minute of life, 40 at 2 minutes of life. Again, it's not so important what is the actual number, but what is the trend of the number? How is it moving? So if it's increasing, even if it's what we would describe as quite low, if it's going up, then this baby is making a normal transition and doesn't need our help. With all this technology, you might say, well, we don't need to look at the baby, but that is a big mistake. And what I'd like to show you is our very first video. This we started doing this well over a decade ago. We took the pulse oximeter to the delivery room and we videoed resuscitations. And this was our first attempt. We were going to make this the subject of a PhD for one of our fellows, Colin O'Donnell. but he went on holidays. And so Colin Morley, some of you will know him, a very famous and experienced neonatologist, and I said, okay, well, while he's away, let's take this thing to the delivery room and just see what happens. Some things, sometimes you learn from your own mistakes. Here you can learn from our mistakes, and we'll just show you what happened in our first resuscitation. This is a term baby, an elective caesarean section for a breech presentation. I want you to try and remember how many things we do wrong here. You can see this baby is actually quite vigorous. You may have heard him give a little cry. We don't have any numbers on our pulse oximeter yet. Good cry. If you were thinking normally, this would be a normal, healthy baby.
You can take photos, whatever you like.
Still struggling to get a number. I'm starting to get worried. That's me in the gloves. That's Colin Morley's hand holding the pulse oximeter on. The alarm goes off. I've got a number of 7. I've never seen pulse oximetry in the delivery before, so I'm starting to panic and thinking this is really going horribly wrong. I wish I'd waited till Colin O'Donnell came back. Just reminding ourselves that this is a very normal baby. I'm having trouble realising that. I can't stand a saturation of 20 anymore, so I've got to start something. So we have the lights up, please. The punchline of this story is that eventually a midwife recognised that this was a normal baby, took it away from the neonatologist and gave it to the mother. What did we do wrong here? Anybody? Yeah, we only focused on the numbers and forgot to look at the baby who was crying and moving his arms and legs like a normal baby. We're probably a bit shy of the video camera. That sort of makes you think twice. I'm sorry? Yeah, exactly. So we started to behave differently than what we would normally do. What about the application of the pulse oximeter? Yeah, it was very bad. We connected the cable first and then attached it to the baby. We didn't wrap Coban or some sort of tape around the pulse oximeter. You saw Colin just holding it there. You can see he forgot to put gloves on, and he's been rewarded by a stain of meconium on his hand, so that he'll maybe learn a lesson there. But most of all, the main message of this is you really need to know what's normal before you start putting pulse oximeters on babies, because you'll get numbers that you're not used to. Okay, so just almost finished, but just a brief introduction to what we can do with pressure and volume measurements in the delivery room. We moved on from those videos I just showed you to this sort of recording, where we have a more primitive webcam image of what's happening with the baby, but we're getting continuous output on pressures, flows, inspired oxygen concentration, oxygen saturation, and tidal volume measurements, as well as trends over time down here, and 2-second measurements of what's going on. So we're now able much more reliably and accurately to measure what's going on with respect to ventilation in the delivery room. And after lunch, I'll share with you some of the things that we've learnt about that. So those are the traces. So to finish up, in summary, colour no longer recommended as a useful sign in the delivery room. Clinical measurement of the heart rate, whether it's with a stethoscope or palpating the cord, systematically underestimates the true heart rate. Help is on the way. Pulse oximetry is a useful addition to our ways of monitoring babies in the delivery room, not only for oxygenation but also heart rate. Gives you continuous output. You don't have to interrupt what you're doing, but you can see what's going on. But you need to know what is normal, what a normal transitioning baby's heart rate and oxygen saturation is. And don't forget to look at the baby, because you can still learn something by looking. The signs of effective ventilation, the manometer, the chest rise, are imperfect. And we have the capacity to help us understand what's going on with resuscitation using the respiratory function monitor. So with that, I'll stop and thank you for your attention.
Resuscitating the mature asphyctic child with apnea is very stressful, and you don't know if you're doing waiting for the pulse oximetry 1 minute or 1.5 minutes. That's a long time during the first minutes, and it's in the beginning it's all about getting air into the lungs, ventilating. So I find it very useful to letting the nurse keep the stethoscope on the chest, and then you hear when it starts bubbling. That's more, you get a good response of what you're doing, and it's easier than the chest rise.
I think you've made a couple of very important points. Heart rate is probably a better indication of your success in resuscitation than looking at chest movement. So I think that's right. Auscultation is useful. And I wouldn't mean to suggest that you have to wait for the minute or minute and a half before you start resuscitating that pale, apneic, limp baby with a heart rate that's well below 100. Those babies need urgent resuscitation. We'll talk a little bit more about this after lunch, but it's a matter of identifying those babies who need early, thorough ventilation, get in early and take over their breathing, versus the vast majority of babies, particularly preterm babies, where people tend to apply that same philosophy of getting in early and resuscitating when those babies may not need it. So that was the sort of distinction I was trying to make. But I'm not saying... I agree with what you're saying. For that pale, grey, bradycardic, apneic baby, get in, by all means listen to the chest and start ventilating and do it effectively, and we'll talk some more about that this afternoon.
Would you like to comment on good old ILCOR scoring?
Yeah. I didn't show this slide, but it's of no surprise when you're adding up things like colour and heart rate, which are inaccurate, you're going to get an inaccurate APGAR score. And when we've looked at how people agree about the assignment of APGAR scores on videotape, we've given them the heart rate and just asked them to assign the APGAR scores. The agreement is very poor. People will give APGARs as low as 4 and as high as 9 for the same baby at the same time. So APGAR scores not terribly reliable, and people tend to systematically overestimate the APGAR scores that are given at the time. When we compared the APGAR score given by people based on what they saw on video and the true heart rate versus what was actually given at the time, we found they were much lower. So I think we like to feel we've made a difference. So for when a paediatrician goes to a resuscitation, it's very common for them to give a low 1 minute APGAR score and a high 5-minute APGAR score to show how wonderfully they resuscitated the baby, but you can tell I'm a little bit cynical about APGAR scores. People have tried to develop an improvement. My German colleagues will tell you that Mario Rudiger is working on an alternative system, but it's a very hard one to crack, to get a number to reflect how a baby's going. It's probably an inherently flawed idea. We're better off relying on things like heart rate, I think, particularly to guide our resuscitation. No other questions? Okay, thanks very much.